Good morning. Welcome to the study comparing active versus passive learning and also evaluation of inter-observer agreement for endomicroscopy in the evaluation of pancreatic cystic lesions.
Pancreatic cancer is arguably the deadliest cancer. The mortality nearly matches its incidence. The incidence is also increasing. Currently, it's the third leading cause of cancer-related death, and by 2030, it's expected to be the second leading cause of cancer-related death. The question is, how can we shift the mortality curve for pancreatic cancer by screening individuals at risk? Pancreatic cancer starts from two key types of precursor lesions. One of them is the pancreatic intraepithelial neoplasia, so-called PANIN lesion. These are very difficult to diagnose. These lead to solid pancreatic ductal adenocarcinoma, or solid lesions. By the time you see them on a cross-sectional imaging study, they are nearly 7 to 10 years old. The second kind of lesion, or second kind of source of pancreatic cancer, are pancreatic cystic lesions. The precursor lesion here is a mucinous pancreatic cyst with the potential to turn cancerous over time. These cysts are incidentally detected during cross-sectional imaging studies. There are two types of pancreatic cystic lesions, the mucinous cyst and the non-mucinous cyst. Under mucinous cyst, we have IPMN, intraductal papillary mucinous neoplasm, and mucinous cystic neoplasm, otherwise MCN. The resection of these two precancerous mucinous cysts is based on international consensus guidelines. The non-mucinous cysts include some benign and some neoplastic cysts. Serous cystadenoma, otherwise SCA, have a benign outcome. Although it's a neoplasm, it's typically not resected because these rarely ever turn malignant. Pseudocysts are benign cysts, which are an outcome of acute pancreatitis. Cystic neuroendocrine tumor, or cystic NET, do need resection based on certain criteria. Solid pseudopapillary tumor, otherwise SPT, also need resection. Finally, lymphoepithelial cysts are rare and they are lined by squamous epithelium and are typically benign. However, they are resected because they are often misdiagnosed as mucinous cysts. Although pancreatic cystic lesions offer a distinct opportunity to identify precursors to pancreatic cancer and improve outcomes, pre-surgical differentiation of these cysts is very challenging, and that is the crux of the problem. It is challenging to accurately classify cysts into premalignant mucinous versus non-mucinous lesions. Further, it's challenging to diagnose a specific type of pancreatic cyst. With the current standard of care, which is suboptimal, that's using clinical features, imaging studies, and EUS, including cyst fluid analysis, the best diagnostic accuracy in a prospective study was 79%. That is, nearly 20% of patients can remain unclassified with the current standard of care. When I say unclassified, it's where we cannot classify them into a precancerous mucinous versus a benign non-mucinous cyst. Because of this difficulty in classifying cysts into precancerous mucinous and non-mucinous cysts, there are multiple guidelines, starting with the initial guidelines in 2005 to the latest international consensus guidelines in 2017. Interestingly, the standard of care, which uses imaging studies, EUS, and cyst fluid CEA, hasn't changed since 2004. So it's high time that we improve the diagnostic accuracy from the current 75 to 80% to something higher than 90%. Briefly, this is the updated 2017 guidelines for resecting a mucinous pancreatic cystic lesion. They are divided into high risk and worrisome criteria. The high risk criteria is where the main pancreatic duct is dilated to more than a centimeter in size, or the patient has jaundice because the cyst is blocking the bile duct, or if you see a solid nodule within the cyst. These are the so-called worrisome criteria according to the 2017 updated guidelines. These are called worrisome, meaning that it's kind of an accumulating evidence that may lead to a resection in a younger patient. Here, the main duct is dilated but less than a centimeter. The patient has clinical pancreatitis because of the cyst, or the cyst is more than 3 centimeter, or the cyst has thick wall or a non-enhancing nodule within the cyst, or the cyst results in an abrupt change in pancreatic duct size, and the three recent additions, which is increased growth of the cyst of more than 5 millimeter every 2 years, presence of lymphadenopathy, and or an elevated CA19-9. The very fact that we have guidelines is because we don't have a good way to accurately diagnose and risk stratify these lesions. Because of this deficiency in diagnosis, there have been two key areas of diagnostic studies which have been investigated. One of them is molecular analysis of the cyst fluid, which is a DNA analysis of the pancreatic cyst fluid, recently by next generation sequencing analysis. The second modality is an imaging biomarker, which is endoscopic ultrasound guided needle-based confocal laser endomicroscopy. Basically, it's microscopy of the pancreatic cyst in real time. Endoscopic ultrasound guided needle-based confocal laser endomicroscopy, otherwise EUS-NCLE, is an endoscopic procedure. Since the study participants includes medical students and residents who are not familiar to endoscopy, this is similar to routine endoscopy except that the scope tip has an ultrasound probe and we can see across the gastric wall or the duodenal wall. So once the scope is introduced into the stomach, as the picture indicates, once you see a cyst, the needle is actuated from the endoscope into the cyst. Once the needle is in the cyst, a tiny probe, which is less than a millimeter in size, which is actually preloaded in the needle, is then advanced through the needle into the cyst. Once the tip of the probe touches the epithelium of the cyst, we get a video feed, or we get images of the cyst wall on a processor, which is shown in this picture. As here we see that there is a cyst in the pancreas and a microscopic image of finger-like projections or papillae are seen in this picture. This is a typical case of a IPMN lesion, which is a kind of mucinous cyst.